You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about presentation of acute coronary syndromes. We'll first go over the fourth universal definition of MI and a framework for thinking about troponin elevation. We'll then talk about biomarkers and lab testing. We'll then talk about presentation, including physical exam and history of present illness, scoring systems such as GRACE and TIMI, and then end with MI in specific territories such as RV infarction or atrial infarction. The fourth universal definition of MI. There's considerable confusion in terms used to describe troponin, including terms that are imprecise, such as troponin leak, or deprecated, such as type 2 NSTEMI. What's the difference between myocardial injury, ischemia, and infarction? I'll give you a systematic approach to the new paradigm as defined by the fourth universal definition of MI from 2018. You can follow along using the flowcharts in a paper by Maya et al. 2024 in Diagnostics. First, is the troponin above the 99th percentile upper reference limit, or URL? If so, then there is myocardial injury, regardless of the underlying cause. Myocardial injury can be acute or chronic. Second, is there a dynamic rise or fall in troponin, defined as more than 20% of the baseline troponin? Although newer recommendations include defining the rise and fall based on an absolute delta. If so, that is acute myocardial injury. Then, is the troponin persistently elevated above the 99th percentile upper reference limit without a dynamic rise or fall? If so, that is chronic myocardial injury. Third, is there any of ischemic symptoms such as exertional chest pain, new ischemic ST, or Q wave changes on ECG, new ischemic wall motion abnormalities on echo, new loss of viable myocardium on perfusion imaging, evidence of a new coronary thrombus? If so, then that is acute myocardial ischemia. If there are no ischemic ECG or echo changes and no ischemic symptoms, there's likely no myocardial ischemia. It would be more appropriate then to call it a diagnosis of non-MI troponin elevation due to specify the underlying cause. Fourth, myocardial infarction, or MI, is defined by the presence of both acute myocardial injury and evidence of myocardial ischemia. Pathologically, MI is typically characterized by myocyte necrosis and or apoptosis within hours. There are actually 5, not 2, categories of MI. Type 1 MI refers to plaque rupture and or erosion, which can occur with or without an occlusive thrombus. Type 2 MI refers to MI where there is no plaque rupture or erosion. Type 2 MI can occur from increased oxygen demand alone, such as tachyarrhythmias, or from reduced oxygen delivery alone, such as severe anemia, hypoxemia, or bradyarrhythmia. It is possible for supply-demand mismatch to occur on top of baseline atherosclerosis. Type 2 MI can also occur from alternate processes such as vasospasm, microvascular dysfunction, or coronary artery dissection. Type 3 MI refers to cases of sudden cardiac death with ischemic ECG changes such as ventricular fibrillation and or symptoms suggestive of myocardial ischemia. Type 4 MI refers to PCI-related MI. 4A is PCI-related MI. 4B is in-stent restenosis-related MI. Thrombosis-related MI. And 4C is in-stent restenosis-related MI. Then type 5 MI is CABG-related MI. Fifth, if there is ST elevation on ECG, then the type 1 MI is a STEMI. All else falls under the umbrella of NST ACS. According to current guidelines, the terms STEMI and NSTEMI should only be used when referring to type 1 MI, not type 2 MI. The term type 2 NSTEMI is a misnomer. It does not exist anymore. When you have a type 2 MI, document it as type 2 MI secondary to specify the underlying condition. Sixth, note that each disease entity, such as anemia, exists on a spectrum. It can present in isolation with no myocardial injury, with myocardial injury, or with acute myocardial ischemia leading to myocardial infarction. For example, A patient with a drop in hemoglobin, normal troponin, and no anginal symptoms, ischemic ECG changes, or echo findings has no myocardial injury. A patient with a drop in hemoglobin, an elevation in troponin, but no anginal symptoms, ischemic changes, or echo findings has what you call myocardial injury without myocardial ischemia. Whereas a patient with a drop in hemoglobin, elevation in troponin, and either anginal symptoms, ischemic changes, or echo findings has myocardial injury with myocardial ischemia, resulting in myocardial infarction. Interpretation of serum troponin elevation relies on integration of ECG, echo, physical exam, interview, and other imaging and laboratory data. This includes careful consideration of alternative etiologies of troponin elevation alongside the possibility of ACS. Next, biomarkers and lab testing. The 2021 AHA-ACC guideline for the evaluation and diagnosis of chest pain says, in all patients who present with acute chest pain, regardless of the setting, an ECG should be acquired and reviewed for STEMI within 10 minutes of arrival. That's a Class 1 recommendation. In all patients presenting to the ED with acute chest pain and suspected ACS, cardiac troponin should be measured as soon as possible after presentation. Class 1. In patients presenting with acute chest pain, high sensitivity cardiac troponin is the preferred biomarker because it enables more rapid detection or exclusion of myocardial injury and increases diagnostic accuracy. Class 1. What exactly does high sensitivity mean? The term high sensitivity does not refer to one specific technology for measurement or one specific form of troponin being measured, but refers to any assay that meets two criteria. First, its total imprecision, as defined by the coefficient of variation, or COV, at the 99th percentile value is less than or equal to 10%. Second, measurable concentrations below the 99th percentile should be attainable at a concentration value above the assay's limit of detection for at least 50% of healthy individuals. In the old non-high sensitivity troponin assay, troponin peaked around 12 to 24 hours of the onset of symptoms, so it had to be trended every 6 hours. The peak level generally correlated with the size of the infarction, but in the new high sensitivity assays, it is no longer necessary to trend every 6 hours to peak. 0, 1, 2, and 3 rule in, rule out algorithms are the new standard. There are many of these algorithms that exist. The ESC chest pain guidelines endorse a specific ESC rule in, rule out algorithm, but the AHA ACC guidelines do not endorse a specific algorithm. In patients presenting with acute chest pain, they say, the AHA ACC chest pain guidelines I'm referring to, that serial troponin I or T levels are useful to identify abnormal values and a rising or falling pattern indicative of acute myocardial injury, Class 1. In the evaluation of patients presenting with acute chest pain and suspected ACS for whom serial troponins are indicated to exclude myocardial injury, recommended time intervals after the initial troponin sample collection, time 0, for repeat measurements are 1 to 3 hours for high sensitivity troponin and 3 to 6 hours for conventional troponin assays, Class 1. That's what I was talking about. For patients with acute chest pain, a normal ECG and symptoms suggestive of ACS that began at least 3 hours before ED arrival, a single high sensitivity troponin concentration that is below the limit of detection on initial measurement, time 0, is reasonable to exclude myocardial injury, Class 2A. So this is a new feature that you couldn't do with the non-high sensitivity assay, a single hour 0 rule out. Okay? CK and CKMB, which you may have learned about many years ago in medical school, are no longer recommended for the diagnosis of acute MI. Specifically, the 2021 chest pain guidelines say, with availability of cardiac troponin, creatine kinase myocardial enzyme and myoglobin are not useful for diagnosis of acute myocardial injury. Class 3, no benefit. CRP will be 5 times higher on average in patients with ACS compared to patients with stable coronary disease. Patients with the highest levels of CRP are at increased risk of death, even if cardiac troponin levels are not elevated. Patients with UA and STEMI and elevated white blood count, which is a nonspecific marker of inflammation, do have higher mortality rates of recurrent MI compared to patients with UA or NSTEMI and normal white blood count. Those are the pearls for biomarkers and lab abnormalities in ACS. Now we'll talk about the presentation itself. In the 2021 AHA-ACC guideline for the evaluation and diagnosis of chest pain, the term atypical angina has been thrown out and replaced by the term non-cardiac chest pain. Non-cardiac should be used if heart disease is not suspected. Although the term atypical chest pain was originally intended to indicate that angina is occurring without the presence of typical chest symptoms, in practice, it has been more often used to state that the symptom is of a non-cardiac origin, which is not true. Therefore, they would like to retire the term. The 2021 chest pain guideline says, chest pain should not be described as atypical because it is not helpful in determining the cause and can be misinterpreted as benign in nature. Instead, chest pain should be described as cardiac, possibly cardiac, or non-cardiac, because these terms are more specific to the potential underlying diagnosis, Class 1. To assist in the use of cardiac, possibly cardiac, and non-cardiac chest pain, they instead presented a graded list of adjectives in 5 categories. High probability of ischemia is chest pain that's described as central, pressure, squeezing, gripping, heaviness, tightness, exertional or stress-related, or retrosternal. Adjectives that suggest a moderately high probability of ischemia are left-sided, dull, and aching. Adjectives that suggest a moderate probability of ischemia are just stabbing. Now, adjectives that suggest a moderately low probability of ischemia, i.e., suggesting a non-cardiac cause, include right-sided, tearing, ripping, and burning. Finally, adjectives that suggest a low probability of ischemia, i.e., high probability of non-cardiac etiology, are sharp, fleeting, shifting, pleuritic, and positional. Do not use the Diamond-Forrester model anymore for pretest probability. Now we have specific averages for each age group, which you can find in the 2021 chest pain guidelines. Ischemic symptoms in women more commonly include nonspecific fatigue, sleep disturbance, and/or shortness of breath, rather than crescendo chest pains. The 2021 chest pain guidelines also bring in special considerations for older adults. In patients with chest pain who are more than 75 years of age, ACS should be considered when accompanying symptoms such as shortness of breath, syncope, or acute delirium are present, or when an unexplained fall has occurred, Class 1. Therefore, it is important not to be dismissive of elderly individuals who present with a fall or with syncope or acute delirium. There are 3 ways to qualify for the diagnosis of unstable angina. You can have rest angina, which is angina at rest, prolonged for more than 20 minutes, occurring within 1 week of presentation. Or you can have new onset angina, that's angina that started within 2 months of presentation. Or you can have increasing angina, which is previously diagnosed angina that is now distinctly more frequent, longer in duration, or lower in threshold. Women with coronary disease are more commonly found to have preserved ejection at presentation than men. ECG should be repeated every 15 to 30 minutes for the first hour during the evaluation of a patient with ongoing symptoms, an initial non-diagnostic ECG, and a high clinical suspicion of ACS. When we talk about nitroglycerin being contraindicated by recent phosphodiesterase inhibitor use, that refers to 24 hours of sildenafil or vardenafil use, or within 48 hours of tadalafil use. Oral beta blockers should be initiated within the first 24 hours of ACS presentation in patients who do not have any of the following: signs of heart failure, evidence of low output state, increased risk for cardiogenic shock, Other contraindications of beta blockers, such as PR interval more than 0.24 seconds, second or third degree heart block without cardiac pacemaker, active asthma, or reactive airway disease. If if a patient with chest pain has a less than 1% risk of a 30-day event, you can actually discharge them and do an outpatient evaluation. That's explicitly stated in the 21 chest pain guidelines. Now we'll move on to scoring systems. The Global Registry of Acute Coronary Events, GRACE score, and the Thrombolysis and Myocardial Infarction, TIMI score, are among the most commonly used scores for risk stratification in ACS. So let's look at what variables make up these scores. The GRACE score for risk of in-hospital mortality for ACS sums a number of integer points from the following variables: Killip class, systolic blood pressure, heart rate, age, creatinine level, cardiac arrest at admission, ST segment deviation, and elevated cardiac enzyme levels. The TIMI score for risk of 30-day mortality in unstable angina or NSTEMI, which is different from that for STEMI, sums up the number of points for the following variables, with 1 point for each variable: age of at least 65 years old, having at least 3 risk factors for CAD, such as hypertension, hyperlipidemia, diabetes, current smoking, or family history of early CAD, prior coronary stenosis of at least 50%, although this requires that that patient have had CCTA or invasive angiography before, aspirin use within the last 7 days, having at least 2 anginal episodes in the last 24 hours, ST deviation of at least 0.5 millimeters, or elevated cardiac biomarkers. A TIMI score of 2 or higher requires a delayed invasive strategy, that's cathing in 25 to 72 hours, while a TIMI score of 3 or higher requires an early invasive strategy, that's cath in 3 to 24 hours, whereas a TIMI score of 0 or 1 is given an ischemia-guided or conservative strategy. The immediate invasive strategy, meaning cath within 2 hours, is recommended in NSTEMI/unstable angina patients who have refractory angina, signs or symptoms of heart failure, new or worsening mitral regurgitation, hemodynamic instability, sustained VTAC or VFib, or recurrent angina or ischemia at rest with low-level activities despite optimal medical treatment. Again, these are the factors that would make you do an immediate invasive strategy, cath within 2 hours for patients with NSTEMI or unstable angina. Then an early invasive strategy, meaning cath in 3 to 24 hours, is recommended in NSTEMI unstable angina patients who have none of the stuff in immediate invasive, but who have a GRACE score that's more than 140, a TIMI score that is 3 or higher, a temporal change in troponin, or new ST depression. Then a delayed invasive strategy, meaning cath in 25 to 72 hours, is recommended in NSTEMI or unstable angina patients with none of the stuff in immediate invasive of early invasive, but who have a GFR less than 60, EF less than 40%, early post-infarction angina, recent PCI within 6 months, prior CABG, GRACE score of 31, a GRACE score of 109 to 140, and TIMI score of at least 2. Then an ischemia-guided strategy, which is the new name for conservative management, is recommended in NSTEMI or unstable angina patients who have a GRACE score that's less than 109, a TIMI score of 0 or 1, or patient or clinician preference in the absence of high-risk features. There is also a TIMI score for 30-day mortality risk in STEMI that's different from that for NSTEMI or unstable angina. The TIMI score for 30-day mortality in STEMI sums up the following variables with associated points: 3 points if the age is 75 or higher, or 2 points if the age is 65 to 74, 1 point if there is a history of diabetes, hypertension, or angina, 3 points if systolic blood pressure is less than 100, 2 points if the heart rate is more than 100, 2 points if the Killip class is 2 to 4, 1 point if the weight is less than 67, 1 point if anterior ST elevation or left bundle branch block is present, 1 point if the time to reperfusion therapy is more than 4 hours. Now, you've heard me mention Killip classification at least twice now. Killip classification is a CHF symptom classification used specifically in patients with acute MI. CLIP Class 1 includes individuals with no clinical signs of heart failure. CLIP Class 2 includes individuals with RALs or crackles in the lungs and S3 or elevated JVP. CLIP Class 3 describes individuals with frank acute pulmonary edema. CLIP Class 4 describes individuals in cardiogenic shock or hypotension, defined as systolic blood pressure less than 90, and evidence of peripheral vasoconstriction such as oliguria, cyanosis, or sweating. The CLIP classification does not apply to CHF patients who have not had an MI. In terms of what you find when you finally send them to the cath lab, 15% of patients who present with unstable angina will have no significant coronary artery disease on angiography. 1/3 of patients who present with unstable angina will have impaired coronary flow without explicitly obstructive lesions, suggesting the presence of microvascular dysfunction. The short-term prognosis is excellent in these cases. In patients with unstable angina found to have a culprit lesion, the responsible plaque is typically eccentric, with overhanging edges consistent with a disrupted atherosclerotic locus. IVUS of culprit lesions in unstable angina will often show soft echolucent lesions, indicating a thin fibrous cap and lipid-rich core, and fewer calcified lesions compared to patients who present with stable angina. Now we can move on to talking about the last section, which is MI in specific territories, starting with RV infarction. RV infarction presents with a triad of hypotension, jugular venous distension, and clear lung fields. There are 3 reasons why RV infarction causes hypotension. Decreased RV contractility leads to reduced blood flow to the left ventricle and a decrease in its preload. Additionally, elevated RV end diastolic pressure displaces the septum towards the LV, which reduces LV compliance and filling. RV dilation within a non-compliant pericardial sac also leads to increased pericardial pressure, which restricts LV filling and can result in the equalization of diastolic pressures among the various heart chambers. On echo, RV infarction can be distinguished from other causes of RV hypokinesis by the presence of LV inferior wall hypokinesis. Although PE also has RV free wall hypokinesis, pulmonary embolism would have sparing of the apex. RV infarction will produce a hemodynamic profile that resembles patients with constrictive pericarditis, where there is elevation in RA and RV pressures, a prominent or rapid Y descent in the RA, and an early diastolic dip and plateau sign or square root sign. RV infarction patients will also have a Kussmaul sign. What does that mean? Normally, the JVP falls with inspiration due to reduced pressure in the expanding thoracic cavity and the increased volume afforded to right ventricle expansion during diastole. When RV infarction or constrictive pericarditis is present, as one inspires and pulls through blood in the right heart pressures rise rather than fall because there's no way for the infarcted or constricted right heart chambers to accept additional volume. This results in Kussmaul sign, the paradoxical increase in JVP that occurs during inspiration. Kussmaul sign can be seen in constrictive pericarditis, tricuspid stenosis, severe cor pulmonale, and right heart failure, including right ventricular infarction. Echocardiography can easily distinguish RV infarct from constrictive pericarditis. RV infarct will have RV dilatation and depression of RV systolic function. If you see an inferior infarction on ECG, before giving nitroglycerin, you should do the right-sided ECG to rule out RV infarction so you don't cause iatrogenic hypotension. Lead V4R, i.e. ECG with a V4 lead in the right rather than left midclavicular line, is very sensitive for right ventricular infarction. IV fluid should be given in RV infarction to maintain normal left-sided preload, as I described for the reasons above. The contribution of atrial contraction to RV filling is important in patients with RV infarction. So, in patients who have a pacemaker who get RV infarction, atrioventricular sequential pacing will improve hemodynamics. Now we'll talk about the special case of atrial infarction. Atrial infarction occurs in 7 to 17% of autopsy-proven cases of myocardial infarction. The left atrium is supplied by the LCX, while the right atrium is supplied by the proximal RCA. If atrial infarction is present, it is usually in addition to left ventricular infarction and more commonly occurs as right atrial infarction rather than left atrial infarction. This may be because the left atrium has well oxygenated blood from the lungs, which could help nourish an ischemic atrial wall. Atrial infarction will have supraventricular arrhythmias such as AFib, sinus arrhythmia, and wandering atrial pacemaker. Occasionally, but rarely actually, atrial infarction may lead to rupture of the atrial wall. Finally, we'll end by talking about collaterals. What are collaterals? These arteries are small 20 to 200 micrometer vascular channels that interconnect epicardial coronary arteries. Collateral arteries exist at baseline and are normally closed and non-functional because there's no pressure gradient between the arteries they connect. When an acute coronary occlusion occurs, the distal pressure drops suddenly and any pre-existing collateral vessel opens quickly. The increased flow through these rudimentary collateral vessels trigger three stages of a maturation process. In the first 24 hours, there's passive widening due to increased flow. Over the next several weeks, increased flow and shear stress trigger endothelial cell activation, causing inflammation and cellular proliferation with fragmentation of the basement membrane, dissolution of the extracellular matrix, and recruitment of leukocytes. Over the next several months, the collateral vessel wall thickens from deposition of extracellular matrix. This results in a 3-layered vessel wall that is nearly indistinguishable from a normal coronary artery. The luminal diameter of a matured collateral vessel can be as large as 1 millimeter. Diabetes mellitus reduces the endothelial production of nitric oxide, which may impede the ability of collateral vessels to develop in patients with diabetes. Collateral vessels ultimately cannot provide the same amount of blood flow as the native coronary circulation, but can supply up to 50% of the normal coronary blood flow. In an acute MI, the presence of collaterals decreases infarct sizes and contributes to improved survival. So, we've now talked about the fourth universal definition of MI, biomarkers such as high sensitivity troponin and CRP, the presentation of ACS, scoring systems like GRACE and TIMI, and MI in special territories. That's all for this episode on the presentation of ACS.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.